Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'll be interviewing Dr. Robert Nielsen, a family physician who is Medical Director of PinnacleHealth Medical Group in Harrisburg, Pennsylvania. Dr. Nielsen, thanks for joining with us this morning.
My pleasure, Larry. Good to be with you.
So your system, PinnacleHealth system, is I think, doing a remarkable job of preparing itself for value-based payments, moving into the bold new era. And this morning, we'll talk a little bit about how you're integrating behavioral health and clinical pharmacy into your system to improve the quality of care, reduce the cost of care. So could you talk a little bit about how that began and what it looks like now?
Sure can, Larry. We started, as we do with many of our projects, modeling innovations in one or two sites and begin to get some feedback as how they're working, how it impacts the patient care, what kind of quality metrics we're looking at, and then begin to look to how we roll that out and deploy that across the system. So on the behavioral health model, we started with a local behavioral health firm that we contracted with to come in and co-locate in one of our practices, not only from a standpoint of doing the typical quote-unquote counseling sessions, but also to become part of the healthcare team, to be fully participatory in our day-to-day activities, available for warm handoffs, available for attendance at our team meetings, and to work with our care coordinators to try to optimize care plans. As I'm sure you're very well aware, that when you start to bring in other players to the stage, the story on your patients and the portrait that you can paint of their needs can become much broader and give you a much better perspective on how what their perceived needs are, as well as how they view their treatment plan. So often we find that in our 15 or 20-minute visit with a patient, there just isn't enough time or opportunity to get into some of those complexities, and as we use our behavioral counselors, the feedback is really valuable as to what some of the barriers and obstacles are to achieving our goals.
Cool. And then has it grown beyond, how widely has this been disseminated through your system?
We're starting to roll out. We have a couple other practices who have begun to be involved, and then we're looking, our geography covers 5 counties in south central Pennsylvania, and we're hoping by the first part of 2017 to have embedded behavioral health in all of our practices. There's been a great literature base done on this, a lot of the work done out through the Intermountain Group, who has a wonderful program on embedding and co-locating behaviorists, and how they can impact not only the psychosocial needs of the patient, but also help us deal in chronic care management. You know, their work has clearly shown that about 2/3 of patients with our standard 5 or 6 chronic care diseases, about 2/3 of them need kind of routine care, and about 1/6 of those patients really could benefit from some behavioral contact, whether it be a social work contact or barriers to health care. And then clearly another 6 really need some more intensive therapy and intervention. And really their financial outcomes have been very, very nice attached to that. They've seen some great improvements in the quality metrics within the practice, patient satisfaction scores, and from a value-based contracting, also the overall spend has been impacted rather nicely. So we're excited. We're hoping to get this all rolled out. We've obviously have to take a few baby steps first and learn your way through some of the some of the billing issues and some of the supervision issues. But I think we've modeled that out pretty well and are ready to go and roll this down the road a little bit. It's been a great help to us in managing our patients. It's as you find in many of these instances in team-based care, it really leverages the time and the ability for providers to meet the needs of the patients, and like I said earlier, sometimes needs that we're not even aware exist.
Great. Now, do I understand also that you're beginning to integrate clinical pharmacists?
We are. We have a PharmD who has done some great work on some selected projects in our office. We've had a tremendous success in our opioid reduction program, and Megan has been a real leader in that role. But now we're beginning to get into how we can utilize her in the offices, and again, we've modeled this in one or two practices. She's been doing some direct patient care in the office. We've focused on a couple of areas to start with, polypharmacy and the elderly being one. And we've done brown bag days in the office. We've also looked at certain specific disease entities. So we've brought her into the office to help with some group visits for patients who might have congestive heart failure or diabetes and having some difficulty in managing their medications or looking at medication options. In addition, we've used our registries, and she's part of the quality team that looks at our registries and looks at optimization of care and our stage 3 kidney failure patients on the appropriate medications and not on medicines that they should be. So it's been a really interesting experience. Patients have been very accepting of it. I mean, really, when we think about the level of understanding many of our patients have of how they take their medications, and you start to work one-on-one with them, and we're seeing some very nice results in reduction of overall medications and hopefully the reduction of side effects and drug-drug interactions. A little too early to say that we've seen data that impacts on our hospital utilization or ER utilization. Intuitively, we think that data will be there as we look at it 6 months or a year down the line. But certainly the impact on the patient and the clinical relationship with the practice has certainly been enhanced.
That's great. So, what impact is this having for the docs in the office? You know, the hamster wheel is really burning people out, and the hope of team-based care is that reduces the workload on the primary care providers. What's your sense of that?
We're starting to see that. In the practices that have deployed these models and have utilized the providers as an integral part of the team, we're starting to see the physicians have a little bit better sense of accomplishment. They have the sense that they have a little bit more time to do the things that are truly physician tasks, that they're getting a better sense of the reconnection with the patient. The patients are giving a lot of good feedback about, you know, that young lady who did this or that gentleman who did that, the counselors or whomever, really giving a broader picture. And that's very fulfilling. It's one of the things that's had to happen in those areas. We've had to learn how to be better managers of our time and our people. You know, we're so accustomed to being the heroic physician with everything on our shoulders, and you know, the more we can pile on, the more successful we are. And as you begin to realize how self-destructive that is, we've had to learn a new set of skills. You know, how do you do the handoffs? How do you trust other people? How do you coordinate those activities and have the conversations so the patient's goals are met? and to make sure that those conversations and that managerial time can be done in such a fashion that it does not it's not time prohibitive. And so we've had to learn some new skills. We've had to learn to be able to hand off some responsibility and change a little bit of our perspective on what our role as a physician entails.
That's great. So how do you do that within a system like yours? Do you have group meetings? Do you have kind of in-service lunches? What's your process?
Yeah, I think, Larry, we all of the above and then a few other things. I think one of the things that, I think in healthcare today and certainly in primary care, is many of us feel so much of the push down of needs and demands, whether it be from insurance companies, healthcare systems, whomever. And so while certainly we want to frame this as much as we can in a efficient way by larger group meetings, organizationally we have quarterly meetings for our entire staff, and we try to choose the topics that we present at those quarterly meetings to be directly related to how we transform care and how we link care to other aspects of our healthcare system. We have every 2 weeks, we have what are called site leader meetings, where each of our sites, and we have 17 or 18 of those sites now, Larry, that gets together and again refine some of that. But what we've really found most effective is going out to the practices. And we try to take our management team or our educators or our trainers or our patient engagement people on a regular basis to focus on how we adapt to this. What does the new system look like? And to do it very much on a frontline ground basis, showing people what skills have been there, where their current situation is, and then how their outcomes move over time. Not only does that help with the engagement and the training, but I think it conveys a message of we care and we're there, and some of us have actually done this, and be able to share the stories of how it's enhanced our care. And that way, it's not so much a didactic session as an experiential session. Most of us, I think, learn better from an experiential type of learning environment.
Sure. Yeah, let me also move on to another topic. You had mentioned something to me about co-locating team members. Was that in the practice out with the chicken processing?
Right. Well, this is one of the most exciting parts of my professional career through the years, and it's now pushing 40 years, so there have been a few exciting moments. But about 6 years ago, just through a fortuitous contact in the community, with actually I was in the gym working out one morning. One of the CFO of a local employer was commenting how their health care bills were going up. They had access problems. They were a self-funded insurance company. And so I offered, would you like us to sit down? And the long and short of the company is a very high-end chicken processing plant in Lebanon County that sells nationally and is well known for its very nice benefit package and being a great place to work. They were self-funded. They had about 1,200 employees and maybe 1,400 covered lives at that time, and their spend was approximately $4.3 million. And they really saw this escalating at a very, very rapid rate. So we met, talked about what their goals and objectives were, and from a businessman's perspective, their CEO did about as good a job of enunciating the IHI's triple aim than I've ever heard. So we thought we had a pretty reasonable basis to formulate some plans and some beginning plans. So we co-located in their plant, and it's now 2 plants, a primary care office. We staff it on a part-time basis there, and began to examine the barriers their staff was having with regards to getting health care. These are people who had good insurance, but were not getting the care they needed, or if they did, were tending to receive it through more expensive venues such as emergency rooms and urgent care centers. We didn't do anything fancy. We did a lot of, minor musculoskeletal type of things and minor illnesses, and then began to roll into doing some chronic care management there and some preventative care. And began to realize that, again, our population is in 2 counties. They come from both Lebanon County and Berks County. About 80% were Spanish-speaking, a lot of transportation barriers. And as we began to explore things, it was their doctor's offices closed at 4 o'clock in the afternoon, and there was no way for them to get their lab work because they didn't have a car. And some of these are, pretty easy fixes. You have the lab come twice a month, and now they have access to a laboratory. So as we started to look at this, in the first 9 months that we were there, we saved them about $900,000. And Larry, we didn't do anything fancy. I mean, really, this is pretty basic primary care and family medicine. And so the question then became, how sustainable would this be? So we're now in the covering about 1,800 employees and about 2,200 covered lives through our clinics there. And 6 years later, they are spending less money than they did 6 years ago. So somebody who's much smarter than I am in actuarial spend and things like that has calculated, and we have an insurance partner in this, who is the claims processor and all, that our annualized savings for them was about 33% year over year for the last 6 years. So we're pretty excited about that. We're moving into a much more aggressive program to look at preventative care and how we deliver that on a more complete basis. We've had to deal with some of the confidentiality issues because, again, we have a computer system that's up there, and we have had to make sure the employees understand that the employer does not have access to their health records. We've had to look at how we bridge language barriers. And then the real positive thing is we've been able to connect many of these patients with our own practices. We have a rather extensive availability in the evening in our practices, so that when we're not in the clinic up at the chicken processing plant, we're able to service the needs of these people, see them in the office, and because we're on the same electronic record system, obviously, give them a more complete level of care. So it's been a real fun experience. A lot of hugs, a lot of pats on the back. I can't buy myself a cup of coffee when I go through the cafeteria. So all those things that make you feel good about what you're doing and tend to refocus what you as a primary care physician can do and the impact you can make in people's lives. It's really been a neat experience. We've been approached now by within our PinnacleHealth system to look at how we could duplicate that for other employers in the region. And we have a very excellent outreach program to employers, and we're now looking to see how we can build on that basic data set and actually begin to help some of our employers provide care in a similar manner. It's kind of a really nice place to be. It's kind of a fun place to be, and I think we're doing a lot of good for people.
That is fantastic, Bob. Thank you for sharing that story, and thank you for this interview. And Bob, I'm wondering, would you be willing to describe or tell us your email address in case people want to reach you?
Sure. My email is rnielsen, Nielsen, @PinnacleHealth.com. PinnacleHealth.org. It's P-I-N-N-A-C-L-E, Health, H-E-A-L-T-H, all one word, and it's all lowercase letters.
Great. Dr. Nielsen, thank you so much for sharing this information with us today, and I look forward to seeing you soon at our Innovators Network.
Look forward to being there, Larry. Thanks very much. Thanks for your time.